All right, so today we'll discuss about pain or say psychology of pain. Pain seems to have an obvious function. It provides constant feedback about the body, enabling us to make adjustments to how we sit or sleep. Pain is often a warning sign that something is wrong and results in protective behavior such as avoiding moving in a particular way or lifting heavy objects. Pain also triggers help seeking behavior and is a common reason for patients visiting their doctor. Pain also has psychological consequences and can generate fear and anxiety. From an evolutionary perspective, therefore, pain is a sign that action is needed. It functions to generate change either in the form of seeking help or avoiding activity. However, pain is not that simple. Some pain seems to have no underlying cause and functions to hinder rather than to help a person carry on with their lives. Such pain has a strong psychological component. Researchers differentiate between acute pain and chronic pain. Acute pain is defined as a pain that lasts for 6 months or less. It usually has a definable cause and is mostly treated with painkillers. A broken leg or a surgical wound is an example of acute pain. In contrast, chronic pain lasts for longer than 6 months and can be either benign in that it varies in severity or progressive in that it gets gradually worse means with time it gets even more intense. Chronic low back pain is often described as chronic benign pain, whereas illness such as rheumatoid arthritis results in chronic progressive pain. Most of the researchers describe in this chapter is concerned with chronic pain and which hold on, shows an important role for psychological factors. Imagine a small child falling over. They look up at you and you have a split second to turn their experience into nothing or pain. So if you say, never mind, up you get, and smile enthusiastically, chances are they will get up and carry on playing. But if you look frightened and say, oh, that must have hurt, give me a cuddle, then they will cry. In that split second, all the psychological factors that influence the pain experience come into play and translate the signals being sent to the brain into something that hurts or something that is okay. Without these factors, pain would be considered a sensation. But this example illustrates why pain is considered a perception and not sensation. So, pain is a perception and not sensation. If their arm is hanging off, they will cry regardless of what you do. Okay. Early pain theories. Let's talk about how different theorists or psychologists came up with theories regarding the pain, how it actually is being felt. Pain as a sensation. Early models of pain described it within a biomedical framework as an autonomic response. Autonomic response means it's embedded in our nervous system to an external factor. Descartes, perhaps the earliest writer on pain, regarded it as a response to a painful stimulus. He described a direct pathway from the source of pain, example, a burnt finger, to an area of the brain that detected the painful sensation. Von Frey, 1895, developed the specificity theory of pain, which again reflected this very simple stimulus response model. He suggested that there were specific sensory receptors which transmit touch, warmth, and pain, and that each receptor was sensitive to specific stimulation. This model was similar to that described by Descartes in that the link between the cause of pain and the brain was seen as direct and autonomic. He suggested that nerve impulse pattern determine the degree of pain and that message from damaged area were sent directly to the brain via these nerve impulse. So this was under pattern theory, which was developed by Goldschindier, 1920. Therefore, these three models of pain describe the sensation in the following ways. So, we had these three theories, we could say: specific theory, stimulus response model, and then this pattern theory. So, according to these early pain theories, we can say tissue damage causes the sensation of pain. Psychology is involved in these models of pain only as a consequence of pain. Example: anxiety, fear, depression. Psychology has no causal influence. Pain is an autonomic response to an external stimulus. There is no place for interpretation or moderation. The pain sensation has a single cause. Pain was categorized into being either psychogenic pain or organic pain. Psychogenic pain was considered to be all in the patient's mind and was a label given to pain when no organic basis could be found. Organic pain was regarded as being real pain and was a label given to pain when some clear injury could be seen. So, in later theories, they included psychology in theories of pain. The early simple model of pain had no role of psychology. However, psychology came to play important part in understanding pain during 20th century. This was based on several observations. First, it was observed that medical treatment for pain, example drugs, surgery, were in the main only useful for treating acute pain. Acute pain means which is lasting for less than 6 months of period. Such treatments were fairly ineffective for treating chronic pain, that is, pain that lasts for a long time, say more than 6 months. This suggested that there must be something else involved in the pain sensation which was not included in the simple stimulus response model. It was also observed that individuals with the same degree of tissue damage differed in their reports of the painful sensation or painful response. Beecher, 1956, observed soldiers. So, what did he do? Beechers observed soldiers and civilians request for pain relief in the hospital during World War II. He reported that although soldiers and civilians often showed the same degree of injury, 80% of civilians requested medication, whereas only 25% of the soldiers did. He suggested that this reflected a role for the meaning of the injury and in the experience of pain. For the soldiers, the injury had a positive meaning as it indicated that their war was over. This meaning mediated the pain experience. The third observation was phantom limb pain. So, the majority of amputees tend to feel pain in the absent limb. This pain can actually get worse after the amputation. The continuous even after complete healing. Sometimes the pain can feel as if it is spreading and is often described as a hand being clenched with the nails digging into the palm when the hand is missing, or the bottom of the foot being forced into the ankle when the foot is missing. Phantom limb pain has no peripheral physical basis because the limb is obviously missing. In addition, not everybody feels phantom limb pain, and for those who do, they do not experience it to the same extent. Further, when individuals who are born with missing limbs sometimes report phantom limb pain, these observations therefore suggested variation between individuals. Perhaps this variation indicates the role of psychology. Now, there comes a very important theory, say the gate control theory of pain. Melzek and Wall in 1965 developed the gate control theory of pain, that is GCT, which represented an attempt to introduce psychology into the understanding of pain. How did they do this? This model is illustrated in figure 13.1, which we'll see later on. It suggested that although pain could still be understood in terms of stimulus response pathway, this pathway was complex and mediated by a network of intricate processes. Therefore, the GCT, gate control theory, integrated psychology into the traditional biomedical model of pain and not only described the role of psychology, physiological causes and intervention, but also allowed for psychological causes and interventions. Input to the gate. Melzick and Wall suggested that a gate existed at the spinal cord level, which received inputs from the following sources: peripheral nerve fiber. The site of injury, example the hand, sends information about pain, pressure, or heat to the gate. Descending central influence from the brain. The brain sends information related to the psychological state of the individual to the gate. This may reflect the individual's behavioral state, example, attention focus on source of the pain, emotional state, example, anxiety, fear, depression, and previous experience or self efficacy, example, I have experienced this pain before and know that it will go away. In terms of dealing with the pain, large and small fibers. These fibers contribute part of the physiological input to pain perception. Output from the gate. The gate integrates all of the information from these different sources and produce an output. This output from the gate sends information to an action system, which results in the perception of pain. Let's have a look at the picture. So this is brain, and we have action system, large fibers, small fibers, physiological stimuli, and this is the gate. So this is say the spinal cord, this is brain, and this is body part, action system. So this is our limb, and if the pain is being sent by large fibers and small fibers in this direction, then brain would affect expectations, experiences, mood, and behavior by sending signals through large fibers and small fibers. How does the GCT differ from earlier models of pain? How does this gate control theory was different? The GCT differs from earlier models in a number of fundamental ways. Pain as a perception. So now GCT has considered pain as perception, whereas earlier it was considered as a stimuli. Pain as a perception. According to the GCT, pain is a perception and an experience rather than a sensation. This change in terminology reflects the role of the individual in the degree of pain experienced. In the same way, the psychologists regarded vision as a perception rather than a direct mirror image. Pain is described as an involving an action interpretation of the painful stimuli. The individual as active, not passive. According to GCT, pain is determined by central and peripheral fibers. Pain is seen as an active process as opposed to passive one. The individual no longer just respond passively to painful stimuli, but actively interpret the and appraises painful stimuli. The role of individual variability. Individual variability is no longer a problem in understanding pain but central to the GCT. Variation in pain perception is understood in terms of the degree of opening and closing of the gate. The role for multiple causes. The GCT suggested many factors are involved in pain perception, not just a singular physical cause. Is pain ever organic? The GCT describes most pain as a combination of physical and psychological aspects. It could therefore be argued that within this model, pain is never totally either organic or psychogenic. Pain and dualism. The GCT attempts to depart from a traditional dualistic model of the body and suggests an interaction between the mind and the body. Now let's see what are the problems with gate control theory of pain. The GCT represented an important advancement on previous simple stimulus response theory of pain. It introduced a role for psychology and described a multidimensional process rather than a simple linear one. However, there are several problems with the theory. Although there is plenty of evidence illustrating the mechanism to increase and decrease pain perception, no one has yet actually located the gate itself. Although the input from the site of physical injury is mediated and moderated by experience and other psychological factors, the model still assumes an organic basis for pain. This integration of physiological and psychological factors can explain individual variability and phantom limb pain to an extent, but Because the model still assumes some organic basis, it is still based on a simple stimulus response process. The GCT attempts to depart from traditional dualistic model of health by its integration of the mind and body. However, although the GCT suggests some integration or interaction between mind and body, it still sees them as separate processes. The model suggests that physical processes are influenced by the psychological processes, but that these sets of processes are distinct. The role of psychosocial factors in pain perception. The gate control theory was a development from previous theories in that it allowed for the existence of mediating variables and emphasized active perception rather than passive sensation. That theory and the subsequent attempts at evaluating the different components of pain perception reflect a three process model of pain. The component of this model are physiological process, subjective affective, cognitive process, and behavioral processes. Physiological processes involve factors such as tissue damage and release of endorphins and change in heart rate. The subjective, affective, cognitive, and behavioral processes are illustrated in Figure 13.2, which we'll see, and are described in more detail below. So these are the, say, affective, cognitive, and behavioral processes. Pain, how much attention we are paying, self efficacy, what kind of meaning we are assigning to the pain, classical conditioning, how we have learned to cope with that, operant conditioning, anxiety, fear, secondary gains, pain behavior, catastrophizing. So let's have a look at this. Subjective affective cognitive processes, the role of learning. Classical conditioning. Researcher, Research suggests that classical conditioning may have an effect on the perception of pain. As described by theories of associative learning, an individual may associate a particular environment with the experience of pain. For example, if an individual associates the dentist with pain due to past experience, the pain perception may be enhanced when attending the dentist due to this expectation. In addition, because the association between these two factors, the individual may experience increased anxiety when attending the dentist, which may also increase pain. Jamner and Tursky, 1987, examined the effect of presenting migraine sufferers with words associated with pain. They found that this perception presentation increased both anxiety and pain perception and concluded that the words caused a change in mood, which caused a change in the subject's perception of pain. This is further discussed in terms of the impact of anxiety. Operant conditioning. Research suggests that there is also a role of operant conditioning in pain perception. Individuals may respond to pain by showing pain behavior, example, resting, grimacing, limping, staying off work. Such pain behavior may be positively reinforced, example, sympathy, attention, time off work, which may itself increase pain perception. The role of affect, anxiety. Some research has explored some how patients worry about their pain. For example, Eccleston 2001 asked 34 males and female chronic pain patients to describe their experience of pain over a 7-day period. The results showed that the patients reported both pain related and non pain related worry, and that these two forms of worry were qualitatively different. In particular, worry about chronic pain was seen as more difficult to dismiss, more distracting, more attention grabbing, more intrusive, more distressing, and less pleasant than non pain related worry. Other research has explored how worry and anxiety relate to pain perception. Fordyce and Steger, 1979, examined the relationship between anxiety and acute and chronic pain. They reported that anxiety has a different relationship to these two types of pain. In terms of acute pain, pain increases anxiety. The successful treatment of the pain then decreases the pain, which subsequently decreases the anxiety. This can then cause a further decrease in pain. Therefore, because of the relative ease with which acute pain can be treated, anxiety relates to this pain perception in terms of cycle of pain reduction. However, the pattern is different for chronic pain because treatment has very little effect on chronic pain. This increases anxiety, which can further increase pain. Therefore, in terms of the relationship between anxiety and chronic pain, there is a cycle of pain increase, and whereas in acute pain, there was a cycle of pain reduction. Research has also shown a direct correlation between high anxiety level and increased pain perception in children with migraines and sufferers of back pain and pelvic pain. In an experimental study, participants took part in the cold pressor test, which involves placing the hand and arm in icy water as a means of induced pain. The trait anxiety was assessed, and some were actively distracted from thinking about their pain. The results showed that both distraction and low anxiety reduce the pain experience. Fear. Many patients with an experience of pain can have extensive fear of increased pain or of the pain reoccurring, which can result in them avoiding a whole range of activities that they perceive to be high risk. For example, patients can avoid moving in particular ways and exerting themselves to any extent. However, these patients often do not describe their experience in terms of fear, but rather in terms of what they can and cannot do. Therefore, they do not report being frightened of making the pain worse by lifting a heavy object, but they state that they can no longer lift heavy objects. Fear of pain and fear avoidance belief have been shown to be linked with the pain experience in terms of triggering pain in the first place. For example, Linton 2000 measured fear avoidance beliefs in a large community sample of people who reported no spinal pain in preceding years. The participants were then followed up after 1 year, and the occurrence of pain episode and their physical functioning were assessed. The results showed that 19% of the sample reported an episode of back pain at follow up, and that those with higher baseline scores of fear avoidance were twice as likely to report back pain and had a 1.7 times higher risk of lowered physical functioning. The author argued that fear avoidance may relate to the early onset of pain. Some research also suggests that fear may be involved in exacerbating existing pain and turning acute pain into chronic pain. For example, Crombez 1999 explored the interrelationship between attention to pain and fear. They argued that pain functions by demanding attention, which results in a lowered ability to focus on other activities. The results indicated that pain related fear increased this attentional interference, suggesting that fears about pain increased the amount of attention demanding by the pain. They concluded that pain related fear can create hypervigilance towards pain, which could contribute to the progression from acute to chronic pain. These conclusions were further supported by a comprehensive review of the research. This indicates that treatment that exposes patient to the very situations they are afraid of, such as going out and being in crowds, can reduce fear avoidance beliefs and modify their pain experience. Belaine and Linton 2000. The role of cognition. Catastrophizing. Patients with pain, particularly chronic pain, often show catastrophizing. Keefe 2000 described catastrophizing as involving three components. What are these components? Rumination, a focus on threatening information, both internal and external. I can feel my neck click whenever I move. Two, magnification, overestimating the extent of the threat. The bones are crumbling and I will become paralyzed. And third, helplessness. underestimating personal and broader resources that might mitigate the danger and disastrous consequence. Nobody understands how to fix the problem, and I just can't bear any more pain. Catastrophizing has been linked to both the onset of pain and the development of longer term pain problems. For example, if in the prospective study described earlier by Linton 2000, the authors measured baseline levels of pain catastrophizing. The results showed some small association between this and the onset of back pain by follow up. Crombez 2003 developed a new measure of catastrophizing to assess this aspect of pain in children, which consisted of three subscales reflecting the dimension of catastrophizing, namely rumination, magnification, and helplessness. They then used this measure to explore the relationship between catastrophizing and pain intensity in clinical sample of 43 boys and girls aged between 8 and 16. The result indicated that catastrophizing independently predicted both pain intensity and disability, regardless of age and gender. The author argued that catastrophizing functions by facilitating the escape from pain and by communicating distress to others. Meaning, although at the first glance any pain would seem to be only negative in its meaning, researchers indicated that pain can have a range of meaning to different people. For example, the pain experienced during childbirth, although intense, has a very clear cause and consequence. If the same kind of pain were to happen outside childbirth, then it would have a totally different meaning and would probably be experienced in a very different way. Beecher 1956 in his study of soldier and civilians' requests for medication was one of the first people to examine this and ask the question, what does pain mean to the individual? Beecher argued the differences in pain perception were related to the meaning of the pain for the individual. In this study, the soldiers benefited from their pain. This has also been described in terms of secondary gains, whereby the pain may have a positive reward for the individuals. Self efficacy. Some research has emphasized the role of self efficacy in pain perception and reduction. Turk 1983 suggested that increased pain self efficacy may be important factor in determining the degree of pain perception. In addition, the concept of pain locus of control has been developed to emphasize the role of individual cognition in pain perception. Manning and Wright 1983. Attention. There has also been research exploring the importance of attention on pain, and much work show that attention to the pain can exacerbate it, whereas distraction can reduce the pain experience. For example, Chapman and Martin 2010 reported that patients with irritable bowel syndrome paid more attention to pain towards compared to controls when exposed to an exogenous cueing task. The result also showed that those who paid more attention to the pain words also reported more symptoms and took more time off work. However, this study was cross sectional in design and only shows associations rather than causal relationship. Further, it addresses attention to pain words rather than pain itself. In the experimental study described earlier, however, James and Harder Daughter 2002 illustrated that increasing attention to pain increased the pain experience using the cold pressor task. I'll repeat. It illustrated that increasing attention to pain increased the pain experience during the using the cold pressor task. Eccleston and Crombez have carried out much work in this area, which they reviewed in Psychological Bulletin 1999. They illustrated how patients who attend to their pain experience more pain and those who are distracted than those who are distracted. This association explains why patients suffering from back pain who take to their beds and therefore focus on their pain take longer to recover than those who carry on working and engaging with their lives. This association is also reflected in relatively recent changes in the general management approach to back pain problems. Bed rest is no longer the main treatment option. In addition, Eccleston and Crombez provide a model of how pain and attention are related. Eccleston 1994, Eccleston and Crombez 1999. They argue that pain interrupts and it demands attention, and that this interruption depends upon pain related characteristics, such as the threat value of the pain and the environmental demands, such as emotional arousal. They argue that pain causes a shift in attention towards the pain as a way to encourage escape and action. This result of this shift in attention is reduced ability to focus on other tasks, resulting in attentional interference and disruption. This disruption has been shown. Give me a moment. Yeah, this deception has been shown in a series of experimental studies indicating that patients with high pain perform less well on difficult tasks that involve the greatest demand of their limited resources. I'll repeat this again. This disruption has been shown in a series of experimental studies indicating that patients with high pain perform less well on difficult tasks that involve the greatest demand of their limited resources. Let's have a look about behavioral processes. Pain behavior and secondary gains. The way in which an individual responds to pain can itself increase or decrease the pain perception. In particular, research has looked at pain behavior which have been defined by Turk 1985 as facial or audible expression. Example, clenched teeth and moaning, distorted posture or movement. Example, limping, protecting the pain area. Negative effect. Example, irritability, depression, or avoidance of activity. Example, not going to work, lying down. It has been suggested that pain behaviors are reinforced through attention, the acknowledgement they receive, and through secondary gains, such as not having to go to work. Positive reinforcing pain behavior may increase pain perception. Pain behavior can also cause a lack of activity and muscle wastage, no social contact, and no distraction, leading to a sick role, which can also increase pain perception. Williams 2002 provides an evolutionary analysis of facial expression of pain and argues that if the function of pain is to prioritize escape, recovery, and healing, facial expressions are a means of communicating pain and to elicit help from others to achieve these goals. Further, she argues that people often assume that individuals have more control over the extent of their pain induced facial expressions than they actually do, and are more likely to offer help or sympathy when expressions are mild. Stronger form of expressions are interpreted as amplified and as indications of malingering. The interaction between these different processes. The three process model describes the separate components that influence pain perception. However, these three processes are not discrete but interact and are at times interchangeable. For example, emotional factors may influence an individual's physiology and cognitive factors may influence an individual's behavior. Further, the different components within each process also interact. For example, association may increase pain in terms of learning. However, it is likely that this process can be explained by changes in anxiety and focus, with places and experiences that have previously been associated with pain returning in increased anxiety and increased attention to pain, therefore increasing the pain experience. Likewise, pain behaviors may exacerbate pain by limiting physical movement, but it also likely that they operate by increasing focus and anxiety. Staying in bed leaves the individual with nothing to do other than think and worry about their pain. Research also indicate that fear influences attention, that fear interacts with catastrophizing, and the catastrophizing influence attentional reinforcement. All right. The three process model offers a framework for mapping out the different factors that influence pain. However, this catastrophizing is probably best seen as a framework only, with a different component being interrelated rather than discrete categories of discrete factors. So in next video, we'll be covering the experience of pain and other background studies and case studies, the role of psychology in pain treatment, and then we'll talk about different types of therapies we have and the outcome of pain treatment and management, the role for pain. And we'll be going through all these things in the next video. Till then, bye bye, take care.